time, and I just need to say some stuff to.
Sure, go ahead.
So, first of all, welcome to James, and welcome Sara, who's our special guest today, and also again, welcome Lynn. And we will get going formally at 5:05, but for people who are joining on Facebook Live, welcome. This is AB1400 CalCare office hours, and we'll get into the details of all that shortly. So sorry, go ahead.
So he was pushing a ballot initiative, as he did with CNA many years ago, when SB 840 was vetoed twice by Schwarzenegger. But as I understand, at least back then, it cost about $10 million to put a ballot initiative on the ballot. And you need at least 80% of the voters voting for it, or it's an expensive waste of time. So it was a very robust discussion today with many, many people posting in the chat, all kinds of dialogue. So it did touch off a really robust dialogue about single payer, both whether it's best to do it on the state level or the federal. So SBUHC was pushed a lot and trying to get more co-authors.
Yeah, no, it sounds like it was a good discussion, and I think it's right to say that in the world of people who support single payer, there's not complete unanimity on some of the questions that were brought up there, and so the focus of this event has generally been on AB 1400, which is a particular approach to doing single payer at the state level in California, represented in one piece of legislation that's in front of the legislature now. And so that's what has tended to be our focus. But that it is true that it exists in a historical context, and also in a context of different views on different issues, and I think maybe you point out different interests who view the issue differently. So let me, but just a second.
Yeah,
we're going to start in 1 minute.
Have you seen Sarah's comment? They can't see it on Facebook.
Let's see.
Yeah,
the Facebook pages isn't working. Can others access? It's giving an error.
Can someone else try? I can't access the Healthcare for All LA page right now at all. It's giving me a fault. Oh, okay. I think it's working now.
You see it now. Yeah. Sometimes a little funny, I think, when you're on it and it's like you create some kind of weird little singularity of, kind of like when you have two mirrors in the bathroom, like they're face each other, and you're like, so, okay, it's 5:05 p.m. and I want to welcome everybody here today who is in the group on Zoom, and also people who are watching on Facebook Live. We are continuing our every Sunday program of doing AB 1400 CalCare office hours. So first, let me just say a little bit who the we are. The we sponsoring this event has been and continues to be two groups with many people in common. Healthcare for All Los Angeles, which is a group of activists in the Los Angeles area, obviously, who are have been working primarily on single payer at the state level for a long time. And then also PNHP, or Physicians for a National Health Program, Southern California chapter, a group of physicians and other healthcare providers and fellow travelers who believe in doing single payer, certainly as the endpoint of all of health reform in the United States nationally, but also see doing that work in one state and possibly the state of California as a road to that. And so I want to welcome everybody here and then just say something about office hours themselves. So what this is meant to be is a place to talk specifically about this bill, and then also to connect experiences and questions, and make a place for people for questions and dialogue, so that we keep educating ourselves and each other, and everybody who's interested about this particular approach. In service of that, I'm very delighted to introduce a special guest host, but somebody who's been really working hard on this issue in so many different ways. So I'm really just delighted to share the hosting duty with her today. That's Dr. Sara Deen, who is a dentist and activist. And in a second, I want to turn it over to her to do a little bit of like introduction to the bill itself. And then we'll just get going on questions, and she'll help us sort of help me, or will help moderate that and try to answer some of those questions. So let me make sure I have, do you want to do some screen sharing, Sara?
I
or do you want to do some talking?
Sure.
Okay, 1 second then. Well, there's nothing. I will just still turn that on just in case we want to do it. 1 moment. And then let me, 1 more second. Let me make you a co-host. And okay, so anyhow, Dr. Sara Deen, please take it away.
Good evening. I'm so grateful to be here. I gotta say, I'm a little bit daunted because the seat is usually filled by the incredible Gina Harris or Maureen Cruz, and I feel utterly inept to fill in for them, but I'm happy to be here and to share this space and time with you all. So I think Ron asked me to introduce AB 1400 and what we were kind of thinking of doing for today. So AB 1400 is a bill that was introduced into the California State Legislature on February 19th by Representatives Ash Kalra, Alex Lee, and Miguel Santiago. I think there's a lot of room for the legislature to work on what the exact implementation of AB 1400 will look like in terms of funding, policies. But I would say if there's one thing that the bill establishes unequivocally, it's establishing single-payer healthcare in the state of California. I think that is the central principle of the bill. And by definition, what single-payer healthcare means is that we are removing very intentionally the healthcare insurance industry from the role of playing disruptor. Currently, whether you're a patient or you're a provider, the insurance industry is constantly meddling in between that very sacred relationship between doctor and patient, nurse and patient. And so what AB 1400 proposes is, hey, legislators, you guys can figure out how to make it happen, but this is what needs to happen. We must establish single-payer healthcare. The insurance industry is causing harm. The insurance industry causes harm to the health of Californians and then lies to us about it. So for me, that's how I understand the bill. I am willing to have conversations around all of the other features of what implementing that single-payer healthcare could look like in California, but I think that is the fundamental piece, the core, the crux of the bill. So what we were going through different ideas for what we could do for today, and I've been thinking it would be great to create space for folks to share their own healthcare story, or we're calling them CalCare stories. And I'm pretty sure that every single Californian and American has a CalCare story. And what is a CalCare story? A CalCare story is your own personal story of a time where the healthcare industry failed you, your family, your loved one, where a decision had to be made because of either cost cutting or coverage issues where a decision was made because the insurance industry may have directed your care instead of the doctor recommending the best care for you. What I mean by that is, as a dentist, there were so many times when I was practicing where I had to tell a patient, this is what you really need, like a dental implant or a partial denture, but your insurance will only cover this. I have removed a whole mouthful of teeth before to deliver complete dentures. And as a dentist, there's nothing more tragic than doing that, removing all of the teeth from a patient's mouth, offering them a prosthetic, which will never be the same as their actual teeth, because the insurance wouldn't cover better treatment. They wouldn't cover the root canals or the bridges or whatever else I was recommending. And it's miserable for anyone who's had a complete denture after. So you create the molds before the day of surgery. And I'm sure everyone's had those where the dentist puts the goop in your mouth and you feel like you're going to suffocate. So, you take the molds and you preemptively prepare the denture. So the dentist and the lab actually does that work, the artistry work. The lab has to guesstimate what your mouth is going to look like once the teeth are extracted and the bone has completed healing, which takes about 6 to 12 months. And that takes a couple of several dental appointments to take some records to best guesstimate what your mouth will look like. But we, of course, never get it right because your body is unique. Then the day of surgery comes and you extract. It's not fun for the dentist or for the patient. And you deliver the dentures that day like a Band-Aid, essentially. And the patient goes home super swollen. It's a very uncomfortable 6 weeks to 3 months. But so often that's the only treatment that insurance will cover. And it shouldn't be that way. I should have been able to tell my patients, hey, this is the best treatment for you. We're going to save your teeth. We're going to make it so that you can eat comfortably, so you don't get malnourished and the rest of your health isn't impacted. But unfortunately, that's not the world we live in right now. So that's why this bill means so much to me. And I think I went on a little bit too long. But should we ask folks if somebody wants to share their own CalCare story? Does anyone have a story, whether it's a personal story, a family member, a time where the health industry really failed you? Lynn, I see that you unmuted yourself.
Yes, it's ironic that you bring up that example because I'm just like that patient who you worked with. I have been unable to, I live on Social Security, and I've been unable to afford dental care. So every year I would go to Foothill College Dental Hygiene School and have a student work on my mouth every year. And that's about the only dental care I was getting. When I had a couple of cavities, my dentist that I'd gone to for 20 years gave me some free dental care, but he's retired. So I I Googled dentists who take care of patients without insurance. I Googled that and I got the name of a Willow Family Dentistry. Went in, wonderful staff, wonderful dentist. She looked at my mouth and basically came up with many cavities, root canals, crowns, a partial, because I've already had several teeth removed. I couldn't afford the $3,000 implant. And partial $2,000. The whole bill for all that needs to be done is $10,000. Now, fortunately, you probably know this, but maybe others don't. There's something called Care Credit, the Care Credit Card. And it's designed to cover vet bills, dental bills, health bills. Well, I already had the card because my cat died suddenly of congestive heart failure at the age of 3. That was a $2,000 bill. So I'm paying that off. Then I had to have an infected tooth extracted about a month ago by another dentist. That was $350, which actually was cheaper than usual. But now so all I could afford with the care credit, and they take care credit, not every dentist takes that. And they basically, the dentist bills care credit, and apparently they reimburse like within 5-6 days. So it's very prompt. And then you pay care credit, pay the bill off. After a certain period of time, maybe a year and a half, the interest rate on the balance is 27%. All I could afford was have the cavities filled. That was $1,500. The other day when I saw her, she wanted to do a crown. And I told her, I just don't have the money. I said, is it dangerous? Is it bad for me to go without the crown? Because the tooth is affected, has been stable. The stump has been stable for a long time. Now, on the other hand, I have Medicare, and I had 3 operations, many visits, all kinds of medical things over the last 2 years. Stanford's the most expensive healthcare system in America. My bill, I'm guessing, has been $500,000. I have Medicare and AARP, $250 a month, and I have not owed 1 penny to Stanford. So my medical care is well taken care of, and the coverage for medications and stuff. But I have both stories to tell.
Yeah, Sara, what do you think about that story? What is it?
Well,
and the bill? And
first, Lynn, I do want to thank you for sharing all of that, because that's deeply personal. And clearly you felt it was important enough to share it. You wanted to benefit the rest of us. So thank you so much for sharing all of that personal detail. Secondly, I am so sorry that I know from patients, it's amazing how a teeny tiny little tooth can cause such tremendous pain, right? Because that the source of the pain is it's in our skull, right? And it causes so much pain. And instead of, that's enough to deal with, but have to deal with the credit card and the interest rate and coming up with how you're going to pay for things, that's really egregious. And I'm truly sorry. And I wanted to ask you that question. I think you answered it, that from what I remember with care credit, after 1 year, the interest rate, so they'll tell you it's 0% interest rate for the first year, and then it jumps to something like 27%. I don't have the studies pulled up, but I've looked at it in the past. The percentage of folks that end up in that bucket of having to pay the 27% interest rate is the majority of folks who go into using care credit. So while it's a great tool to get a lot of folks out of immediate pain and trouble, that financial burden once they cross the 12-month mark is really, really catastrophic for so many. And as Dr. Birnbaum put in the chat, CalCare would cover dentistry. So it would cover your dental care. Now, I think the bill doesn't explicitly state which codes or procedures yet. So that's where my conversation with providers has been. This is the time for doctors and dentists to get involved in that negotiation and be part of those who design CalCare, so that we can make sure that our patients, I want my patients, if they need an implant, that's what they should get. I don't want to have to tell patients that you should get this. Unfortunately, you're going to get this very poor treatment only because that's what's going to be covered. So I really hope that doctors, dentists, and providers get more involved in this conversation around CalCare. I'm also going to point out, just because we're live, I have not practiced dentistry for almost 4 years now. So I'm not currently a practicing dentist, but I did teach advanced dentistry at UCLA, and I did practice in Torrance. I don't know, Ron, did you want to add something more?
Well, I do, which is just, but although it's a fantastic discussion, and thank you to Lynn, both of you. I want to point out something very important that Lynn sort of, a few things that Lynn exposed for us. And so one is that Medicare, which is a program that covers primarily people who, senior citizens, also some people who are disabled and some other specific medical conditions, very significantly doesn't include dental care. And also some other important types of healthcare. Doesn't deal much with certain aspects of mental health, doesn't deal with a lot of things related to eyes. A lot of people will say the neck up stuff. Doesn't pay for glasses, doesn't pay for hearing aids. And so that it's important for people to get that Medicare doesn't solve all these problems for our seniors. In fact, it leaves them wide open and exposed to all these problems. And that's, I think, been part of Lynn's really hard experience. And this bill will change that. And it does so by enumerating benefits that include those things. And yes, the list of benefits, which is one section in the bill, is not it's pretty detailed, but not infinitely detailed. And some of that is of necessity. Some of it has to be dealt with at the sort of the way the law is executed, as opposed to in legislative language. But the people who have also called single payer healthcare Medicare for all, in fact, really prefer that we say improved and expanded Medicare for all, right? Because Medicare leaves a lot of holes. And so it's also important then also for people to realize who are like, oh, well, I don't have to worry about that because I have Medicare or whatever, that no, those are things that we do need to worry about for our parents and for if you have Medicare. So that's just what I wanted to add there. So should we go to see if there's a next story?
I think Dr. Bill's hands up, and I just want to add one more thing about this gaping hole in our healthcare system right now. As if your oral health doesn't impact the rest of your body, right? It's well documented that periodontitis, for example, can impact diabetes, causes heart disease, it can cause strokes, it can lead to preterm labor. So, and delivering a deep cleaning to a patient from the payer's perspective, for the cost of paying for a patient to get their teeth deep cleaned is far less than treating or taking care of a child that was born preterm or managing diabetes and health disease. So it really is just such a darn shame that we ignore and neglect oral health. And like you said, everything that's neck up. Sorry, I think Dr. Bill has had a hand up.
Dr. Bill.
Oh, well, thank you. Thanks, Dr. Sara and Lynn, for sharing your own dental story. I was just going to share that as an emergency room physician for many years, I saw over the years more and more people coming into the ER for untreated dental conditions, and how penny wise and pound foolish is that we don't take care of dental conditions, like you said, when a deep cleaning would prevent it from going on to becoming a serious oral infection that then requires even IV antibiotic or someone to be in the hospital or major oral surgery at that point, even, or in intensive care with sepsis. So, how much more costly is that? And who's paying for that? We're all paying for that. So, if somebody comes into the emergency room, we're all paying for that. So, so none of us should be satisfied with these, commercial profit first insurance companies. As you say, the insurance industry, well, I don't even like to call it an industry, because industries like make things, or provide essential services. This is not, that's not what they are. I mean, it's not even like banking that actually kind of holds your money and then does, useful things with it, presumably. But insurance companies really are pooling our money acting as a risk pool that, you know, we can do ourselves. I mean, the public can do it ourselves. We do it already in the case of Medicare for seniors and disabled. So why aren't we doing this for dentistry? And then we can pay for all that good primary preventive dentistry that will keep people from neglected care and ending up in the emergency room, you know, for treatments that they would otherwise not need. So you know, that it's really good that that this is coming out because you know, we're what's that expression? Paying Peter to, you know, and Paul. I can't remember the expression, but it's cost shifting. The cost of this has been shifted onto us as taxpayers and ratepayers, and it's for the benefit of these robber barons in this, you know, non-productive industry that's just kind of soaking us, you know, and stealing this money at the same time as you very rightly have pointed out, creating misery and death for individuals. And there's nothing about that we should tolerate. So thank you.
You've brought up such a great point. I really want to ask this question to anyone who thinks single payer isn't the way to go. What is the insurance industry adding to the equation? When folks say people love their insurance, their healthcare insurance, what are they really saying? I would assume most people love their doctors. They love their nurses. They might even love the clinic or the hospital they go to. But what do folks mean when they say they love their insurance? What value, as Dr. Bill said, what value is the insurance companies adding to your healthcare experience? It's a very important question. The underlying assertion is that doctors and providers would be wasteful or inefficient. I think that is the underlying assumption, which as a provider is so deeply offensive. For anyone that's gone to medical school or dental school or podiatric school, the seriousness with which we take our oath to honor and preserve life above all, I would assert that, and the insurance companies do not take such an oath. Their job is to maximize profits, reduce costs. Now, certainly, doctors are not all perfect, and sure, there might be some occasional overbilling or misbilling, but to create this entire, and I'm not using the word industry either, I'm like, what can I say? The insurance companies to babysit doctors is highly problematic. I don't know if Dr. Bill, if this has come up yet. My brother is an emergency room physician actually in Boston. And the number of times he has called me from the emergency room in Boston to say, I have a patient here, they have a wound or an injury in their mouth, or they've had a swelling, I need to do he's like, I need to do stitches. Now, an emergency room physician does not necessarily have the expertise to do stitches in areas that will impact the aesthetic gum line of a patient, that will permit the lips to move freely. That is not a skill most of the time that the average emergency room doctor has. And so I've got my brother here on the phone going, how do I start the stitch? That's really messed up, that patients are put in that situation where they're going to the emergency room for dental care. And I'm so sorry, Adriana, we'd love to hear from you.
Hello, first of all, I'd like to say that this is an amazing movement and I'm all for it. I'm currently a student in North Carolina, and I don't have private insurance. And through some previous work I had done in Spain when I was there for the summer, I had concrete in my teeth through some faulty, I guess, dentistry. And when I went to the clinic, they charged me $800. And since then, I've just been trying to recuperate that and make that money back. And I really think that in general, we have to change the status quo of how people see dental care, because people most of the time see this almost second level hygiene, which is not true. It's almost like the entrance to your body. So I really agree with what James had mentioned in the comments of how we should kind of not only re-educate, but also in a way teach people about the importance of dental care. And I really think that through this movement, we're not only going to have people not go bankrupt through procedures they need, but also educate people on the importance of having good dental care. And I really think that this will be a very good stepping stone for other kinds of movements like this as well. Thank you.
Thank you, Adriano, for sharing that. And actually, I want to connect a couple dots between your experience and Lynn's experience and the issue of bills and what it would be like if you didn't get bills at point of service when you sought care. And so I'll bring up a couple things in that regard and in relationship to the bill. So one is that AB 1400 ends premiums, but also ends cost sharing, things like co-payments and deductibles, and any of the things where at the moment of care, you have to make a decision about whether you're going to be paying for something or not, because that's not the right time to begin with. But it also, it's worth mentioning too, well, what is the status then of things like insurance companies or something like care credit? Because there's actually some similarities in a way, which is that they're, I think, sort of in keeping with what Dr. Bill was saying, these are, I guess we'll just say, financial services organizations, but they may, I guess, claim they're adding value in some way to something in the economy or to health or something, but they're really not, because as Dr. Bill said, the bearing of risk for healthcare is something that very easily could be borne in the public sector, just as we bear risk for putting out fires and all kinds of other things in the public sector. But what they do then is extract money from the system that could be used for things like providing care for people or covering everything. These are, so how then specifically does the bill deal with that? Well, you would never have to have a care credit if you don't have a bill to pay at the time that you get healthcare, number one. And how would insurance companies' role changed in the system? Well, one is that the bill makes it so that no insurance company could offer insurance products in California that cover the things that are covered in CalCare. It essentially excludes them from, it just makes it sort of like an illegal service to sell, that you just can't do that. Or very, very narrow exceptions, like they're able to provide insurance for a college student from out of state who hasn't become yet a resident in California. So let me stop that there and just see, let's see if there's other people who have stories you want to share, questions.
I just want to add a comment on the topic of care credit. I think there's an argument to be made that care credit, that is really predatory lending, right? You're loaning to people from a dentist perspective, you're loaning to people when they're in acute pain, they have an emergent need, and you're saying, hey, don't worry, I'll take care of your bill today, but come tomorrow, I'm gonna gouge you, right? 27%, that is the interest rate I remember too. That's predatory. And why do we live in a world where care credit is becoming the primary insurer for so many dental patients? And the interesting thing with dentistry is, first of all, very few people have dental coverage. Medi-Cal offers very basic coverage, but most people don't make the cutoff, right? The income cutoff to qualify for it. Dental disease, lots of dental disease is preventable. You can prevent cavities for 8 or 9 out of 10 patients. You can have some genetic predisposition to cavities, but for the most part, dental cavities can be prevented completely if you get that your regular every 6-month checkup. You're getting your teeth cleaned, you're getting that checkup. The cost of paying, if CalCare covers those preventative dental checkups, we're not going to be footing bills for implants and dental bridges down the line, because you can prevent all of those negative, poor outcomes in dentistry largely by footing the bill for that much more inexpensive treatment of cleanings and preventative exams. Same with oral cancer detection, right? So I just wanted to add that. But yes, I would love to hear from more folks that are joining us today.
James, I think I see your hand up. James?
Unmute, it always helps. So a friend of mine's a diabetic, and he went through this excruciating process of daring to change insurance companies. So he needs a steady supply of insulin. So try transition insurer 1 into insurer 2 was an absolute nightmare. And he almost had to go, the new insurer wanted him to wait 1 month for his new insulin to start, and the old insurance wanted to cut him off straight away. And I said to him, 8. And he said, 8 what? And I said, 8 times is the number of times you need to call your insurance company and say, you will pay, I have paid my insurance premium to that date. You will give me my insulin. Anyway, they didn't, but his new insurer started a little bit early. He said, he goes, if I die, I can't pay you insurance premiums. That was his argument. And they said, yeah, I suppose you've got a point there. And I said, you really had to go through that nonsense. And I said, you do realise that nowhere else on the developed planet is that even a conversation in the developed world. So yeah, he's an AB1400 aficionado. He's not hopeful, and I said, well, not with an attitude like that, but keep making your calls. Thank you. I yield my time.
Hey, James, so was your friend then uncovered for a period of time?
He said it was about 2 weeks. So he had enough. What he did was he bought some because it only has a limited lifespan in the fridge, like the vaccines. So he had the foresight, and I said, oh no, so now you have to go through additional stress. I think he had to put the extra doses on credit card because they only let you buy so much in advance, because I think you're going to become a drug dealer or something and sell it on the black market. But it threw him out. It was, apart from the stress, but he had his steady supply of insulin because he needs it, 3 times a day. He's a type 1, it's not a type 2. So yeah, I mean, I said, you shouldn't have to go through this. This is nonsense. I wasn't that polite about it, but I said, call out your insurance company, tell them how inhumane they are. And I said, and don't call customer service, go to the CEO. I don't know if you write them a letter, but that's their job. Their job is not to take care of people. Their job is to take care of their shareholders.
Those 2 weeks where he was uncovered, I'm guessing he was working, living his life, but was it something he was thinking about? Because if he ended up in the hospital in those 2 weeks, he would not be covered, right?
So he was transitioning jobs, but I think he had to ask for a severance pay or something in advance, and maybe a small loan from his mum, like a couple of hundred, just that bridging stuff. Like, it wasn't like $10,000 or anything, but I said, but why do you need to think about that anyway? Like, why would a rational, normal human being have to go through that process when the rest of the developed world does not?
And with CalCare, he would have been covered. He would not have any gaps. We would all be automatically covered at all times.
And I said, and you're not going to get more insulin than you need or less insulin than you need. Like, people are arguing you're going to abuse the system. Like, how? What are you going to do? It doesn't get you high. It just keeps you alive. So, and even in the future, and I said, you do realize that there's the long-term insulin. I think it's injectable and it lasts for a month. And I said, you do realize your basic plan wouldn't even think about that. So if that's what you need, that's what you get. It's not like going on a resort and saying, well, everyone's going to want the 5-star option. And I said, it doesn't work that way. It's not first class travel. So I was really angry.
I'm really happy that for your friend, it was just 2 weeks of that anxiety and that he was healthy. But there are folks like that every day that live every day terrified of getting sick. I think I've shared this story with a few of you. I have a friend, a dear friend, my son's best friends. They are asylum seekers. They're here legally. They filled out all their paperwork as they are supposed to. The mother is an adult, and like I said, legally here, all paperwork is complete. She works, she pays taxes. She has no healthcare insurance. So she tells me all the time, Sara, I cannot get sick. I cannot get sick because my sons would have nobody. She got into a car accident in 2019. She got into a car accident, was not familiar with how, you know, the ambulance came. She was driving with her 2 boys. They took her to the local hospital. The bill was, I think, $11,000. And first of all, for her to, and she's an educated person. She was an architect in her home country with a master's from a prominent university in Africa. But going through the paperwork pursuit, because the hospital started sending her bills, you know, there was the ambulance bill, the emergency room bill, the physician bill. It took us 6 months. And at the end of it all, what happened was she ended up at a private hospital because that's where the closest emergency room to her. And so at the end of it, it was the private hospital wrote off her $11,000 bill. But that is not the way this should have happened. She should have been covered. That 6 months of going back and forth and then this private hospital offsetting the cost. It's such an inefficient use of resources, and the grief that, you know, her family endured in that 6 months is atrocious. But I'm glad that for your friend, it was just 2 weeks. A lot of people live their lives like that every day.
Especially fixed income folks, because it's their fault that they're diabetics or need dental care or whatever the case may be. I don't think so. We've got a job to do, people.
No, and James, I think one thing that the story illustrates is like a truly nefarious element of our current system that would go away if we pass something like AB 1400 into law. And that's the idea of eligibility for healthcare, which sounds innocuous when placed that way, but it sounds almost kind of like a bureaucratic sort of category. But it's really sort of like a moral category of failure, not of your friend, but of our system, which is that the only really moral category for eligibility is that you're a human being with a beating heart or a recently beating heart. And everything else is irrelevant. And yet our current system, with its multiplicity of payers, simply can't accommodate that idea, right? And so the eligibility requirements in CalCare are quite few. You have to be a resident of California. People would be essentially automatically enrolled at birth. And then there's a straightforward process for enrolling somebody who would move into the state. And then there's never any other circumstance in which that would be your eligibility disappears. And it essentially ends the question of eligibility. And the thing that sounds so simple but when you get into what the opposite of that is, like what we have in our system now, you get into both the sort of all these stories of people who either live in fear or experience the horror of losing those things, often at the times when they need them the most, right? And so sometimes, for example, illness makes you lose your job, and then you lose your insurance was through your job, and then now you lose your health care. And even just simple things like moving, or going from being 25 years old to 26 years old, or going from, and all that entails. The change of plans may result in the change of which healthcare providers you can go see, including maybe a change from somebody you've been seeing your whole, who's been taking care of you for a long time, who There's incredible costs in the lost knowledge, right? The needing to order the tests again, and so there's an economic, healthcare economics name for all the economic loss to people constantly changing plans, and that's called churn. So churn is one of the sort of hidden taxes in our current system. So let me just leave that one there. And
the other thing you just pointed out, the other thing I really admire about AB 1400, it puts the responsibility of risk bearing squarely on the shoulders of CalCare, right? Like this story that James shared, you've got two insurance companies, neither one of them wants to bear the risk, neither one of them wants to take the responsibility for caring for this human being, right? But if AB 1400 is passed, we establish CalCare as a single payer. CalCare now bears all responsibility for all bills, right? If something doesn't go right, if an outcome doesn't happen, we hold CalCare accountable. As opposed to right now, what happens when somebody has a negative health outcome because of a coverage issue? It's a circus. Sorry, Dr. Bell, please.
No, that was a really great point. And I just wanted to add to the discussion we were having earlier about insurance companies acting as a risk pool. But actually, the situation wouldn't be so bad if that's all that they were doing. But actually, it's much worse than that, because they're also in a position to make medical decisions. So they are actually medical decision makers as well. And that makes them the real death panels. Big insurance and big pharma are the real death panels, not doctors, not governmental agencies, certainly not nurses and hospitals. It's those people who pay the bills. And when you have a third-party intermediary who is saying they are or are not going to pay that bill, and telling you you can or cannot have this or another medical procedure because they don't cover it, that means that they're willing to let that patient die, suffer and die. And we all know that Americans now are dying at a faster rate than all the other advanced countries, people in advanced countries around the world. And that was never truer than what we're seeing now with COVID, during COVID, where we are literally dying more quickly, succumbing to this disease than every other advanced country. They're doing so much better. And that's because we have vampires literally in charge of the blood bank. I mean, weed or foxes in charge of the chicken coop. They're the ones who have become the death panels and deciding who's going to live or die in this country. I mean, the best story I know of is Wendell Potter's story when he worked for Cigna Insurance Company, and they denied Natalie Sarkeesian, a beautiful 17-year-old girl, a liver transplant like 7 times, and then the Cigna finally authorized it on the day that she died from her liver failure. They finally authorized her transplant. I mean, how is that even a thing? Why is that possible? Why did the Attorney General of the state of California, not go after Cigna for in a criminal prosecution, and yet they will try and hold a doctor or a dentist, responsible for malpractice in a given situation like that? So to me, I had, you know, we need CalCare, we need the CalCare board, like you say, to assume that responsibility. It needs to be under public accountability to make those medical decisions, not some commercial entity who's looking after their bottom line and trying to line their pockets. And the same thing is true with pharma. And that's another thing about CalCare, right? Is the ability of California, the 5th largest economy in the world, to be able to negotiate drug prices for the same reason, because pharma has completely overgrown its usefulness in this country, you know, and has become a racket in the sense like the mafia is a racket. They really are guilty of extortion model business practices where they don't charge for insulin or other life-saving drugs based on what it costs to make that product. They charge based on what it's worth to you, what your life is worth to you, to pay them for that product. That's a mafia style of business. And the only way to combat that is for the public to say, we're not going to put up with that anymore. And we need actual champions to push forward bills like this one to make that happen.
I would also say that the question is, how do we define death? You know, you mentioned the death panels. If we're defining death as only that moment where your heart stops, that's one way to look at it. But how about every time a medication isn't covered and it advances how soon your death approaches, right? That happens every single day. And we've talked about it before, like the step therapy, that's the step therapies. I think the word therapy there is completely inappropriate. But I've seen my husband on the phone for 3 hours at a time, arguing with someone from the insurance company on the other end who is not a healthcare provider. Occasionally, it'll be a retired physician who is not from the specialty. So it might be like an ophthalmologist telling my husband about what procedure in gastroenterology is appropriate for the patient. And, you know, they'll say, well, we're sorry. We understand you want to prescribe treatment C, but we want to reduce costs. So we're going to pay for procedure A, even though you're telling us it's not the appropriate choice, but it's cheaper. If that doesn't work, we're going to ask you to try out treatment B. If that doesn't work, then finally, maybe 6 months from now, you can prescribe treatment C. But I would say you're condemning that patient to a premature death right there, whether or not their heart stops that year or not. The toll that puts on the human body when the doctor's already identified the ailment, the treatment needed to remedy the situation, and that patient is being actively deprived of what they need so that the insurance company can reduce their costs. I cannot believe that we tolerate that every single day. Each one of us is constantly moving faster and faster towards death so that we can reduce costs for the insurance companies. And we're okay with it as a country for some reason. Sorry, Ron, I'll let you take it.
No apology. No, thank you for all that. And I'll share one thing also related to that. One of my colleagues, so I'm a dermatologist, but one of my colleagues, not a particularly progressive one, but just one, has been in the habit recently of saying that the prescription pad has now turned into a suggestion pad. Right, and that very often, or as a physician myself, that I know I don't even begin to assume when I saw a patient at visit. I saw a patient at visit 1, and I prescribed XYZ. When I see them at visit 2, I always have to begin with what are you actually taking, and are you taking anything? Because it's entirely not obvious that they will have gotten what I asked them to get. And the ways that happens are many, but it very often involves insurance companies and other factors intervening on formularies and at the level of the pharmacy. So let's see, is anybody, and we can begin to connect some of those things to stuff in the bill. For example, Sara had mentioned that there's a step therapy. Well, AB 1400 ends step therapy because it says essentially that it's not really the place of a bureaucracy or somebody who hasn't seen the patient to make decisions. It should be between that patient and the person taking care of.
So Dr. Ron, what does that really look like? If AB 1400 abolishes step therapy, it means you go see your doctor. Doctor looks at you, says, "Hi, Ron. I've been seeing you for many years now. I know you. I understand your body chemistry. I believe this is the best treatment for you." Ron, you get to look at the doctor's recommendation. And if you feel comfortable, it is your body, you offer your consent, you get to move forward with the treatment. That's what AB 1400 would make happen. And the other thing to point out here is that you would have room for that conversation because the bill also abolishes capitation, right? And I think that's something we don't talk about enough. I know from my dental experience, I can share it from that perspective. Again, I know this is a repeat story for some, but when I first started practicing dentistry, it was at an office where we were 3 dentists. Each one of us had 2 dental chairs. And I was told that I need to produce $6,000 every day. And I could do that however I wanted between the 2 chairs. This is very common practice. I'm just saying it aloud. Most of your dentists will not say this, but the 2 chairs, one was my HMO chair and the other chair was my private insurance or cash chair. So what does the HMO chair mean? Those HMO patients, it was very quickly explained to me because and we're not taught this in dental school, by the way. I was not taught insurance billing. I was taught how to diagnose, how to take a good medical history and dental history, and how to come up with a treatment plan with the patient. That's what I was taught in dental school. I was not taught how to maneuver around insurance companies or how the insurance industry even works. So I remember asking, I don't understand, what does that mean? Like, what is an HMO chair? And so what was explained to me was that for every one of our HMO patients, the office gets a flat payment per year or per month for that person. So if I'm just making up silly numbers right now. Let's say I have 5 HMO patients, which is obviously would not be the usual number for any practice. It would be much higher, but let's just say for easy math, I hate doing math. I have 5 HMO patients, and maybe every year I get $50 per HMO patient, right? That's capitation. What that means is those 5 patients could come in 100 times in the year. I would still only get paid $50. Those 5 patients could come in only 1 time or not at all. I would still only get paid $50. So what is that doing? Am I going to be motivated? How will I make more money? I'm going to make more money if I have a greater pool of patients. So I'm seeing more volume. I don't spend quality time with the patients, and I'm not getting compensated for spending extra time with patients. So as someone who wanted to perform ethical and moral and good dentistry, I did not feel comfortable treating patients in the HMO chair. So what I did was shift as much of my patient pool into the PPO or the private cash patients. But that means my HMO patients were not having the benefit of my technical and my dental skills, which is a huge tragedy. And I still feel really poorly about it. That's how the system is set up by the insurance companies. And that's capitation. And I love that the bill explicitly forbids, abolishes capitation, paying a flat rate for a patient regardless of how much care they need or how much treatment they need, because capitation does not increase efficiency. All it does is decrease the amount of compensation doctors get for taking care of patients who need care, and it pays more for patients that don't need a lot of care. So that's another really shining bright star of AB 1400. And capitation is a word that every Californian should deeply understand, because that's how the insurance industry, I use the word industry again, that's how the insurance companies are directing doctors. They're directing how we treat our patients, how much time we spend. So in that, and I'm coming back to the point that I was trying to make earlier, is under capitation, you need to see volume. You need a high number of patients, so you do not spend quality time. So if we're looking, wanting to come up with a good treatment plan, I want to be able to spend quality time with my patient and not be turning over. I don't know if you guys have heard this before. They're called 10-minute crowns. Has anyone heard the word 10-minute crown? So to prepare a tooth for a good crown, I would say you need at least 30 minutes, can sometimes be an hour if it's a difficult tooth, the access is difficult in the back of the mouth. There's a lot of, they're not dental schools, they're like people teaching workshops on how to cut a 5-minute crown. I've even seen how to cut a 1-minute crown. Why? Because of that capitation. You need to see a high volume of patients. I cannot do a good crown in 1 minute. Most people cannot. It's deeply offensive that there is a 1-minute crown. It looks like we have somebody who wants to share something, Ron.
But yeah, and I asked her to just share that with me before we do it, to make sure it's part of our overall scheme. But just a moment. So I did see that there was a question in the chat from that was also about a definition. It was from, and actually let me stop and say that I want to encourage people, if they either on Facebook or here in the group, if you hear, let me back up and say that most of our hosts have been either have been nurses or physicians or now a dentist, and that sometimes our familiarity with certain terms will make us just throw them out there. And that doesn't mean it's clear to everybody what those things mean. And so I want to encourage people in the spirit of educating themselves as activists or just people trying to understand their healthcare system, then to ask us questions also about words. So for example, and he may or may not know the definition of this, but longtime activist Isaac Lieberman and a nurse asked, what is step therapy? So step therapy is sort of a utilization limitation structure, mostly put in place by some kind of guideline. Actually, I'm going to ask people to maybe to mute if they're that says that a provider, before they can give generally more costly therapy C, that before that they have to try therapy A, and if that doesn't work, therapy B, and that's often in the service of whoever's paying not having to pay for costlier therapy C, but is generally independent of whether the best idea for you as a patient is therapy C, and ignores things like maybe while you're waiting to get from A to B to C, you're suffering. Yeah. So that's the idea of step therapy. In other words, it's one of the efforts that insurers primarily use to limit utilization of healthcare services, and often inappropriately. And likewise, capitation, which I think Sara did a good job of describing, and I'm grateful for that, is also really behind it is a trick of transferring risk. Or as Dr. Bill was saying, it's a kind of a cost shifting shell game of moving risk from from a payer to whoever accepts the capitation. Mm-hmm. And in that sense, then turns that whoever's accepting the capitation payments into a utilization reviewer and limiter themselves.
Well, I think we should talk about why would, for example, a dentist accept a capitation plan, right? Why would someone agree to that? And I know from my own experience, when you're starting out as a dentist, you need patience. You don't have a reputation yet. You're not known. And what the insurance industry company is telling you is, if you accept this capitation agreement, I'm going to lowball you. I'm paying you pennies for doing your dental work, which is why a lot of these HMO dentists for a long time wouldn't do composite fillings, white fillings. I don't know if you guys have that experience. I have HMO dental insurance. They don't do white fillings. They only do the silver fillings. Well, it's because that the rate that they're paying per patient doesn't offset the cost of the more expensive composite materials. But as a new dentist, I'm looking for a patient pool. And so what the insurance company is saying is, we'll give you a pool of patients. We're taking advantage of the fact that you feel vulnerable, you don't have patients, but then you have to be willing to accept this payment scheme, which puts risk on the, that the costlier patients, the patients who have more needs, the doctor, the dentist ends up bearing that risk, right? That I'm giving you a pool of patients. Some of them, you doctor are going to spend a lot more time and money on the patient than what I'm going to compensate you for, but I'm giving you a pool of patients. So it's really good to spell these things out. And like what you said about step therapy, what are we saying? One definition is that it's a fail first, right? You need to provide, patients have to fail on medications A and B before they qualify for C. That means the insurance industry is watching your health deteriorate. Really, that's worth the pause. They're intentionally watching your health deteriorate, because only if your health deteriorates are they going to feel moved to cover drug C, right? That's what they're saying. Doc, I'm only going to pay for the treatment you are saying the patient needs. If I see the patient nearing death, nearing poor health, then we'll pay for it. The insurance companies are okay with that. That's what step therapy looks like. It's really disgusting. Dr. Bill has a hand up, Ron.
Actually, I had it.
Yeah. No, we're not doing general announcements right now, but we can have a couple minutes at the end. So.
Well, it has to do with what you're talking about.
Can somebody is playing. Lynn, are you on Facebook as well? Because there's an echo.
No. I'm on. Oh,
I just want to chime in on the capitation idea.
Sure.
If I could. So I worked in an HMO setting. I worked for Kaiser for 30 years. And I think it depends on the model of practice, because your perspective is absolutely true, Sara, and what you're saying. But there are other models of practice too. So let's say you're in a large group model like Kaiser, and they do, kind of interdisciplinary meetings. Different specialists sit down and decide on best practices that are presumably at least evidence-based. It's not based on, somebody's bottom line, like an insurance company would be, they'll review practices based on their bottom line, or even like, say, drug formulary decisions that are evidence-based, not based on what's cheapest, or, as you were saying, you have to fail on drug A or drug B first. But if there's a drug that has proven itself to be, effective and lower cost. So, a capitation or a global budget, for that matter, can be an effective driver for prevention, to keep costs low on the prevention side. So in other words, if you can keep people healthy, then presumably more of that money actually goes to the group. And so it's not necessarily a bad thing to have a global budget or a capitation, as long as it's not, say, lining somebody's pockets, especially an intermediary or third party that is providing no service. So that's kind of where, you know, I think I draw the line. Yeah.
No, sorry, I actually do want to clarify something related to the bill itself, because I think it does provide for global budgets, and we can talk about how the bill pays for pays institutions and how it pays individual providers. But global budget and capitation are not synonyms. They're not, and the reason they're not is because the global budget doesn't prescribe that like a certain number of human beings are to be cared for. I think it is the case that budget would be. So let me back up a couple steps then. So one of the things that the bill does is it describes basically two kinds of providers. And so those providers are individual providers and institutional providers. So the most typical example of an institutional provider would be a hospital. And the most typical example of an individual provider would be, say, a dentist or a doc or a physician who enrolled as a CalCare provider. And in fact, the bill even describes kind of the need to do provider agreements, basically, kind of a contract between providers and CalCare. And that's true of the institutional providers and the individual ones. So the bill does prevent, or does essentially, not essentially, I think it doesn't use the word capitation, but it essentially doesn't allow for capitation to happen. And by that, it means that when it provides a budget for an institution, that institution can't be closed to just a certain group of people. Essentially, any CalCare provider has to be open, as long as they just have capacity, to any member of CalCare, which equals essentially everybody. So while I do think it may, you know, there may be interesting discussions to have about more and less kind of ethical and efficacious structures, I do want to be clear to people about what the bill describes. And that I think it is accurate that it ends capitation in California.
I think the key difference is the bearing of risk, right? Like in the model that we've talked about with capitation, the provider is taking that increased risk where of a patient that might have greater health needs, and then the provider is going to end up bearing the brunt of the cost or the risk. And I think the bill makes it clear that the only entity that's going to bear responsibility for the financial risk of a patient that's less healthy would be CalCare. And that to me is the other difference.
And in a second, Lynn will let you do your announcement, because Lynn wanted to bring up something about capitation and another resource that people might seek to understand that better. But Dr. Bill makes a point in the chat that I wanted to share. This is some of the worst care that I ever saw patients get in the ER were in my pre-Kaiser days in fee-for-service ER, where I was being pushed to rush patients out of the ER to fill more beds. Mm-hmm. And the way that CalCare, most emergency rooms are part of institutions. And so CalCare envisions paying people who are employees of institutions primarily salaries and not fee-for-service within those institutions. So fee-for-service payments are a part of CalCare, but they're primarily the way that the individual provider would be reimbursed. So that I think that CalCare would not put us back in the days where that you're describing. Now, that there is no system that doesn't at some point create some type of incentives that could be a problem. I mean, I think that that's a sort of elusive goal, but right now we have a system that really intensely has in place perverse incentives that have very little to do with patient care and well-being. So you can debate about what's the best, what are some of the best ways to pay institutions and people. The bill describes a certain set of ways, and I think we should have fidelity to what's in the bill. And then, those are interesting discussions. And in fact, are sometimes some of the sources of disagreements within people who believe in single payer on what some of the best ways to do some of these things are. But the bill takes a certain set of stances on those things. Lynn, did you want to make your announcement? Is she there? Did we lose her?
I think she's unmuting.
Yeah, no, I try to unmute. A couple of things. I've been reading a lot of articles lately, Kip Sullivan, Stephen Kemble, and I believe most of them agreed that global budget is the way to go. And the meeting on Tuesday at 4 p.m. by One Payer States features Stephen Kemble, who's an expert. He's from Hawaii. And he has an article called Trojan Horses, because some of the quote unquote single payer propositions like the New York Health Act are not true single payer. They include ACOs, HMOs, etc. And so you have to, he's warning people to, just because it has the title single payer, these are not necessarily, and they're not very good systems. So if I find the link, if you go to OPS website, the meeting is there, and you should have the link. This is Tuesday at 4. And Kip Sullivan, I had an email I sent out to. He's the health policy person from Minnesota, and he's very well respected. In fact, I just was trying to get is a huge long article that he wrote about, he felt that Bernie's bill was not single payer. And so there are these very interesting experts explaining the difference between these various bills.
That's great. And if you have information about that specific meeting, or maybe it's in that, but Lynn mentions Kip Sullivan and Stephen Kemble, both of whom are long-time members of Physicians for a National Health Program and are and think a lot about health policy. Kip Sullivan is a lawyer. Stephen Kemble is, as she said, a physician from Hawaii, and have a lot of opinions about single payer bills and how we should do some of the, what are some of the best ways and not so good ways to pay physicians and institutions. What I will say is that Healthcare for All Los Angeles did one event with Kip, and both of these folks have studied AB 1400, and they're both supportive of the methodology in AB 1400 in terms of what the best ways would be to pay institutions and to pay individual providers. They have, that's summarizing a lot. They have a lot more to say, I think, than just that. So, back to, let me see, back to questions and people's stories. And
just for a moment, just to bring us back to where we were talking about global budgets and fee for service. Global budgets essentially remove that incentive to see a higher volume, right? So you're not being incentivized to see more patients or to deliver more treatment. Did I lose my internet? Okay, I thought everyone froze for a second. Fee for service, it would look differently in a CalCare world, right? Doctors would not be applying, there would be no pre-authorization process anymore, right? So if I'm a doctor, let's just say I am one of the very unusual doctors that's over prescribing or over treating, right? I have to submit, if I'm a fee for service physician, I have to submit my claim to CalCare, and CalCare has to decide whether or not to reimburse me, right? Whether they're going to give me that fee for the service I have already provided. So I would assume that there would be a lot less wasteful treatment because I would have already delivered that service to the patient when I'm applying for, when I file the claim. And Ron, I thought there was also, and I think it's Kip and Jim Kahn that talked about this, about the fraud, or maybe I'm thinking about the Chaburp report, about the decrease in fraudulent claims under single payer. I don't know if you have a little bit more knowledge on that, or maybe Dr. Bill.
So, well, one thing I could say just about the bill is that or you could, well, if we get into individual providers, so individual, you know, dentists, doctors, occupational therapists, so forth, people who are the ones who would, in our current system and also under CalCare, be the, particularly outpatient setting, be the originator of a bill for a service. That it is the case that the system has, at least envisions, some ideas of looking at, or has some kind of like reporting kind of requirements, or that when people sign up for CalCare that they agree to report some kind of information. But what it takes away specifically is that the reimbursement decisions are tied to some kind of utilization metric or something like that. So any given, so, you know, so for example, I'll just give it an example, like Medicare, which is our nation's sort of single payer with issues for senior citizens, does do some things like look to see if a certain provider is a big outlier in their billing practices, that they seem to be doing something that's very, very different. And, you know, fraud is a thing that can happen in both, you know, in any type of program, public, private, mixed public and private. So all those things, that question, we don't sort of necessarily go to a Shangri-La where like no fraud is possible. But what I would say is that we have a very, very complicated healthcare system, and within complexity is a lot of places for shenanigans. And that simplicity tends to just be much more transparent and simple. And you can just sort of see more clearly if something aberrant is going on. And let me, so that's a
really good point. There's fewer moving parts in a single payer system, fewer opportunities for fraud or waste. It's a really important point.
Yes. And so I'm looking, so in the chat, and, you know, and if somebody is able to share some of the things with the folks in Facebook, I would super deeply appreciate it. You know, so by the way, this group, I'd say this group is relevant to mention one payer states, because what it is a national group of single payer advocates who are interested in the possibilities of single payer happening in a single state. That's what one payer states is about. So is it, James, go ahead, James, and then maybe Sara.
Yeah, okay. With regard to fraud, the European countries that have an insurance-based model, they do regular reporting on types of treatments. Now, if you're starting to get outliers that regularly prescribe certain types of treatment, which may appear unnecessary, they get a call from the health department to justify their choices. So there is a level of oversight for those people that either overly cautious or have very sick people, and they actually do make more money for fee-for-service in some instances. Now, what I tell people with regard to fraud in Medicare, I say liken it to transport logistics. If a package needs to change 10 hands, there's a greater likelihood of it getting lost. If it goes from A to B in the same van, the buck stops with that one person and they can't blame anyone else and things don't get lost into the system. What I did want to ask is about AB1400 in terms of global budgeting. Many hospitals are either teaching hospitals or research hospitals. So if they apply for big block grants and they're using existing patients, this is really true for the pandemic, because I know of studies, there are like 10 campus studies where they're looking at things like reinfection rates and the long haulers and all kinds of things. All that additional money, how does that factor into a global budget? Have we even looked at that, or is that just too far into the weeds?
No, that is actually addressed in the bill. In other words, in a couple ways, in a few different places, because you mentioned a few different things. So one, you mentioned sort of like educational activities, right? Or like academic institutions.
Well, one is, say med students, that's been addressed, but I'm talking about working professionals who are eminent medical experts in their field, and they're doing research studies over and above treating patients. So income's coming in from big block research grants from all over the planet, over and above treating the regular patients.
Right. So there's some things in the bill related to that, although the biggest thing that the bill identifies is, actually let me back up and say something about our current system, which is that it is the case that some insurers will pay more for similar services at academic centers for different reasons. So one is understanding that there may be additional costs at those institutions, and that in fact some patients really want to go to those institutions because they think, oh well, those are the places where the super duper experts are. And so in fact that also becomes to some extent a mechanism in which those highly specialized services are inequitably shared. That they become sort of, for some people, a kind of like little premium gem that's available to some and not others. And that includes a lot at public institutions, which I think a lot of people might find surprising. That places like UCLA or UCSF, or some of our leading public institutions, that they may have deals with some insurance companies, and certainly generally in most cases don't see people on the on Medi-Cal, which is Medicaid in California, which is the program primarily that takes care of poor Californians. So the other thing is that there are provisions for adjusting global budgets or making kind of supplements and that kind of thing related to unexpected events like pandemics. They kind of, the bill came out with it kind of in the shadow of the pandemic. And so there was kind of an awareness of that. And then the bill also provides what's called a special projects budget, which is meant also to send more money to institutions that may provide care to poor communities or people that have traditionally had poor access as a way to remedying that. And if currently, the money flows to places with the highest return, well, maybe that return should be social return as opposed to profits. So those are some of the aspects where the bill sort of provides sort of differential type payments in the global budgets. If that, I think, is what you were kind of driving at.
Special projects to me is something in the jurisdiction purview of CalCare. I'm just talking about external funds, how that impacts like specific research projects. Not if you're an epidemiologist or an endocrinologist or dermatologist and you're doing some testing on some new eczema cream and it's being tested across 10 different sites across the developed world, and they're looking for side effects. It's a new drug for the sake of argument, and you have your group of patients as part of a research project. It's not necessarily tied to the local community. It's
Well, are you talking about the funding of either basic or clinical research? So one thing is that has, with few exceptions, not primarily been the province of state government. And I don't think that would dramatically change under CalCare. In other words, the bulk of research on in the United States on kind of basic science, health science, and also clinical type research is either paid for by the National Institutes for Health, which is a federal organization.
Yeah,
that's part of the Department of Health and Human Services. Also, there's fairly significant money that goes from industry to support certain kinds of research. And the state's role has been limited. You know, there've been kind of exceptions, like for example, in California, I can't remember now if we just renewed it, I should, but for a while ago, we funded stem cell research in California but pretty specifically because the federal government was not doing that. But that's kind of stands out as exceptions. So I think it's mostly outside the purview of the current bill.
okay.
I would just add one thing, that I think the bill is very mindful about calling for transparency and accountability. So I think there is a section in the bill that says that if there is funding for like the kind of study that James mentioned, and the funding is coming from a private entity or a non-state entity, that CalCare funds there has to be some separation, because the CalCare funds are public funds, and those funds they belong to all of us. And they should be held accountable there should be transparency and accountability. So there is some mention in the bill about maintaining that separation. I'm not clear on what that will look like in execution, but I do remember reading that section and noticing that they were being clear that CalCare funds are public funds and they need to be publicly managed, and there should be transparency. As a resident of California, I have the right to know how those funds are being used and distributed. Whereas,
We've got some comments on Facebook finally. Jacinta Mary has posted a few comments. The funny/unfunny one, my dog has better insurance than me. If you're still on, Jacinta, did you want to speak?
is she in the Zoom?
She's on Facebook. It doesn't appear to be a question as such.
If she was able to put her question, or put it in the comments, and we could.
Yeah, I don't think there's a proper question there, but anyway, it doesn't look like she's speaking. But anyway, let's move on to the next person.
Is there another question there? No? You know what I would love to hear? So for those who don't know, who are joining us on live, I only got involved in this movement in February when the bill was coming out. So for me, two of us who've gotten really involved, Dr. Rich Huynh and myself, we ran to be delegates to the California Democratic Party in our district. And after we were elected, we sent out a survey to everyone that voted for us or organized for us. And we said, what matters? You guys voted for us. you're entrusting us with to represent you within the party and in the district. What matters to you? Because that's what we think we are obliged to do, is, you know, honor your vote and support. And so healthcare for all, healthcare was the top vote getter in our survey. This is in the 66th Assembly District, South Bay of Los Angeles. So I only got involved in February. Coincidentally, the AB1400 was, you know, was released by the representatives in the legislature. So we just hopped right on, you know, we spent some time studying the bill, completely fell in love with it. And then we're looking for folks to organize with, and found our way to Healthcare for All Los Angeles. But I know lots of you that are here, who are logged into the Zoom, you guys have been working on single payer healthcare for a really long time. And I've been dying to ask a question, even though I've been in meetings with a lot of you many times. What brought you into this work? I feel like whenever there's passion, there's either a trauma there's a pain there's a frustration. And I would love if some of you here would be willing to share what was that nudge or that push that drove you to pursue single payer? What drives and motivates you? What's your story?
You want to hear mine?
Sure.
It's hysterical. I've told this story 100 times and I still laugh, sadly, and no one believes me. So I got my first job since coming to America, and I got health insurance, and it's like, okay, I'm ready to kill myself now. I don't understand anything here. I wanted to get a prescription, optical prescription, one for contact lenses and one for eyeglasses. So the optometrist said to me, I have 26 plans, optical plans, just from that provider. And I said, well, I just want a prescription, nothing else. What will it cost me? Well, if you buy glasses from us, it won't cost you anything, but you need to spend at least $200. And I said, I don't like your glasses, but what about contact lenses? Well, they cost X and Y. So he spent 30 minutes explaining insurance plans. And I said, you haven't actually answered my question. So, well, which one do you want? And I said, all I want is two prescriptions, one for contact lenses and one for eyeglasses. Like, can you do that for me? And I said, without buying anything from here. And he said, the cheapest option for you is just to tell me you don't have insurance and just pay you $60 for each. And I said, okay, I'm ready to kill myself now. So I called up the insurance company and cancelled. And then they said, would you like to fill in a satisfaction survey? And I said, okay, this isn't funny. What happens if I had a heart attack? My mum's family are all cancer people. My dad's family are all heart disease people. So I have two wonderful choices to leave this earth from. What happens if there's something serious? Am I going to be in an ambulance answering questions about what insurance I have and whether I want fries with that or not? And I said, I'm done. I'm not dealing. I said, you people don't make any sense. And I said, you do really. And even the providers were saying, yeah, I know you're from Australia and this is all insane to you. And I said, insane's putting it politely. And I said, you people got rid of the British. How can you not get rid of these insurance companies? Just don't. And I said, can you refuse to deal with them? And he said, well, if everyone pays cash, then yeah. But one thing I always say is if I get a heart attack or something serious, I can go to Australia on Air Force One, not now, obviously, come back via Hawaii, stay in a 5-star resort, come back to Los Angeles and still have change. And I tell people, I thought I was being facetious, but apparently I'm not. So think about what you're paying for. And when people say, I don't want to hear your questions. They're nonsensical. All these waiting times and everything that you complain about. And I said, well, when I go to the bus stop, I need to wait 10 minutes for a bus. It's not the end of the world. Like the waiting times are based on your need. It's not like you get a heart attack and say, we have an opening in December 23rd. That's 2023, by the way. I hope you make it. And I said, nothing. And they argue that people are coming to America for treatment, and I said, well, look at how many people and why. It's either part of something very specialist or part of a research project, or they like a doctor or something like that. But the majority of people in their home countries get very satisfactory. They seem to think in America, government programs are basically what you're forced into when you can't afford real service. And I said, well, I understand how you got to that point because I'm seeing it. And I'm telling people all that Medi-Cal reimbursement is going to go because it's a complete insult to the medical profession. I asked like when I just get my generals, I see a physician's assistant and they get like $20. And I said, $20. It's like to draw blood, take my blood. I go, that's what your expertise is worth to this company. And I said, no, just refuse to deal with them. And I'm just angry because people are just so drained. They're just, when people are made to feel powerless, they start to become subordinates to the system. And I said, no, you take a break, take a rest, and let the young kids kind of like make noise, but you're the elders, which means you have the knowledge and you know how things work. I speak to all the 70-year-olds about the Rendons of the world, and we need to have financing attached. And I said, like, if I didn't speak to these people, I'd have to learn all that myself. And that's why I love old people, because they're like the oracles. But yeah, eyeglasses. I have insurance I can't use. I'm sure Bernie didn't mean that. And all the other people I know in low-paid jobs, paid jobs, go $6,500 is their deductible. And I said, oh, that's hilarious. So you have to earn that just for the privilege of seeing a doctor in the network. And I said, wouldn't it be funny if that $6,500 was actually like healthcare? What you going to do? And I said, well, you start pestering your Congress, your assembly people. We're going to do this one way or another.
Thank you, James. I just want to point out that if we put our pictures next to each other and ask who's the immigrant, people would point to my brown face. Just random point. I had to throw that in there. But yeah, I think and I don't know, you guys can agree or disagree with me. I think that it's important to remember that even if you're receiving Medicare, our healthcare industry in this country is driven by the insurance industry. So whether or not your bill, what is that?
Mafia.
Yeah.
Not industry.
Yes. So the insurance companies they're setting the rules. They're setting the board game for us. They're determining how the rest of us play, whether it's Medicare or for the patients and whatnot. But Betty, are you going to share your story with us?
Yeah, sure. I will share multiple stories, I guess. I feel like, and maybe people don't realize it, but I feel like our healthcare system has been haunting me, and not in huge ways, or maybe they are to other people, I don't know. But I could remember teenager, first time, mom and dad working. I had severe stomach issue, cramps. My brother got worried. He took me to the ER. They gave me something. They sent me home. My dad, I could tell my dad was the kind of, you knew when dad was like upset, he had this certain thing he did with his lips and his mouth. And it's like, I could tell he's knitting his eyebrows. And I knit my eyebrows a lot. If you see me, people are like, why are you mad? I'm like, I don't know. It's just, I saw my dad all these years and I'm always looking like I have a frown, And he kind of like got like really like, he kept on saying, "How are you doing? Okay. How are you doing now?" But I could tell something was up, and he turned and says, did you have to go to the emergency room? Did you have to go to the emergency room? And I was just like, and he was concerned because he couldn't maybe he had, he didn't know what the bill was going to be and if he could afford it, and that was like the first thing when I was a teenager. As it got time goes by, I'm, an adult. you know, my husband and I are freelancers. We always had to pay for our insurance premiums. It always became an issue. It was always too expensive. Had to do without on several occasions. And I remember when my daughter was really young, everybody got the flu, you know, except for me. I don't know what it is, like that mom power for some reason, where mom doesn't get sick until after everybody's okay, and then she gets sick or something, right? And it's like, and you know, so I remember my husband, like, really, he was actually substitute teaching at the time. We had a real lull in work, and he went to like an urgent care, and the urgent care doctor gave him a prescription. And I think it was like, I don't know, it was like, I know it was like $150 or up, and we couldn't afford it. You know, we couldn't afford it. And I went back to her and I was like, listen, you know, I can't afford this. Can you give me another prescription for something else or something? You know, here I am. My daughter is sick at home. My husband is sick at home. I'm running around and I'm trying to fill prescriptions. I can't afford it. And I go to her and she's like, your husband is very, very sick. And it's like scaring the bejesus out of me. I am so frightened, but I know this. And I'm like, so I just turned around and this is not something everybody would know how to do. I said, okay. I was like, then you must have samples here somewhere. If you have samples of this medication, if my husband is very, very sick and you're telling me this, go get me the sample. So she's like, she actually balked. Well, I don't have the key. I said, then find the key. Find the key, because it was on the weekend. And she gave me the samples for the medication that I could not afford, because she was saying there was nothing else. And my husband was very, very sick. And I was like, so here I am put in this position of having to do this, you know? And, you know, ongoing, my daughter has some health issues, and we've always had to pay for the highest PPO premium in order to her to see the physician that she needs to see, you know, always put in the position. And we have not been able to always afford that. And it's always been a struggle. And then a flip side of this, when my dad was passing and he was in the hospital, and I think I told some people the story before, it was like this weird, like, chain of doctors in and out of his room of like, oh, we have to test him for this and we have to do that and we have to test him for that. And this man, you know, and everybody's in shock, you know, he's older, he's an older man. You know, he's had issues, health issues, but everybody's in shock. When you're in that shock, you don't really know what to do as a family. And I remember this one nurse telling me, and she said, in my country, he would be home with his family. And my father kept on saying, I want to go home. But this whole doctor's coming in perpetually telling us we need this test, that test, this, that test, this to be done, that to be done. It kept us in this like frightful mode where we couldn't really make this clear decision on this quality of life for him, you know, at his end of his life. And it actually ripped the family apart, the whole thing, just the whole thing in the hospital ripped the family apart. So it's an ongoing thing that is like intrinsic in many people's lives in America that they even take in stride, where in other countries it would be unfathomable to even have to deal with this on any level. And we did, my husband and I, through our work together, we've gone to other countries and where, you know, people don't even have this conversation about insurance, you know, like, what are you talking about? I was like, they think we're the boring people talking about the lack of insurance. You know, go to England, you go anywhere else, and they have the care that they need when they need it, you know? And so, but as Americans, I think we've been made to, we just live with this system that is so wrong. And unless you go outside and see an outside perspective from other, you know, even from other countries, you don't really get to understand that this is not the way it should be. You know, we shouldn't have to live this way. And so, yeah, that's some of it. There's some other stories I could put in there, but.
Thank you, Betty. And I mean, those stories that you just shared, like you said, we've normalized those stories, right? You just shared all of those stories kind of in a list format, which almost removes the pain and the trauma that each one of those instances played in your life. I mean, all the way up to the last story that you shared, the story of how so many people die in our country, right? That experience of accompanying someone at the end of their life, where we should be centering that person's wellness, that person's final moments, their experience, their wellness. And instead we have this convoluted and ugly system where the insurance companies, they set the tone, they set the rules, and everyone else is a pawn in that piece, leading to that kind of a scenario where instead of your dad's what would be best for him being centered, it becomes about billing and billing codes and making sure that there isn't anyone getting sued yet. The litigations that arise from this current toxic system that we have, which is all part of this puzzle. So I'm so sorry, especially for the story of your father passing. But you've touched up on so many different things. The prescriptions, that your husband's prescription would be so expensive, and I think we just can't emphasize enough that when we say that CalCare, if we establish a single payer in the state of California, Californians would become a super consumer. We would get to more aggressively negotiate drug prices. And we're not just theorizing here. I would say if we're not able to improve anything, let's just pretend for a second that CalCare and single payer does absolutely nothing else than to make our prescriptions more affordable. Isn't that in and of itself enough? How many billions of dollars we lose? How many people like, your husband, you shouldn't be having to stand in an urgent care, begging, bullying, whatever you did that day, the staff member to give you the
little of both, begging and then finally survival mode, right?
Yeah, we've experienced this
for the
before.
family.
I have a friend who, whenever she arrives at my house, I'm worried. She's gasping for air. She walks a little bit. She's out of breath. And I ask, "Where's your inhaler?" $350 for the month. She can't afford it. She's on, the minimum wage that people don't want to raise so that people can afford their meds too. But that same inhaler, in a different country costs $15, because if you have single payer, you can aggressively negotiate. It's not theorizing. We see it around Earth. Other countries are doing it. We are the only country, civilized country, I hate using that word. We're the only, I don't know what the right word is here, developed nation, I suppose, although that's also a word I don't really like, but that does not set prices for pharmaceuticals. It's really, really shameful. You should not have been put in that situation. And the doctor, that office shouldn't have been put in that situation either, right? You two lost, and the only person that won was the insurance company, right? The doctor had to dish out a sample. I'm guessing the office had a limited supply, and they're deciding who to dole it out to. You ended up in a dire situation. The only person that won is the insurance company. And then having to pay for those of us who might have a sick family member, having to spend extra money on paying for that really expensive PPO, which we've talked about it before. We have a caste system in healthcare, right? The wealthier you are, the better access you have to doctors. And if you don't have money, you get what's left over, right? Thank goodness that you were able to afford that PPO for your daughter so she could get access to the doctors she needs. But what about all the 300, 3,000, 3 million people who weren't able to pay for that fancy PPO? You're muted, Betty.
On the flip side, on the other side of that, my family has been on Medi-Cal, and there is a classist, racist issues in regards, the way people look at you when you are actually on Medi-Cal. I can remember, going, my daughter had a vision ophthalmologist. I made an ophthalmologist appointment. She's on Medi-Cal, and we get there and we were just like, when you feel something's up, something's weird, and we were getting, she was only 3 years old, and we were being told, waiting so many. And I was like, and then I could hear whispering, people looking, just a weird overall feel. And I said, is there something up? Is there something happening here? And the assistant looked over to me and she said, we are you weren't supposed to get this appointment. And I was like, what do you mean? And she's like, people with your insurance shouldn't have been slotted for this appointment. So basically what she was saying to me is that they only reserve so much time for the Medi-Cal patients. And I happened to get a appointment. Somebody made a mistake, and therefore I was being begrudged this at the office, and they were making me wait while they were putting other people ahead of me, I guess.
Mhm.
And, so, that's a shock to the system too. So you work yourself to the bone to make sure that, your kids get the care they can, and, you pay for something that you can't really even afford so they can get the care they can and not be treated like that, because that's how people are treated on Medi-Cal. They either can't find anybody to care for them, or they're treated like that by, and I'm not saying it's everybody. I'm not saying it's every doctor, but it happens.
But coming back to the point you made about racism and classism, I love that the bill very intentionally addresses the social determinants of health disparities. And the bill sets an intention that the CalCare board is going to address any of the other social or economic factors that lead to different outcomes in different populations, and set aside pockets of investment dollars to put towards the care of communities that are falling behind or that have poor health outcomes. So I love that at least in two places, the bill clearly addresses disparities in healthcare and taking an intentional approach to addressing those. It is something I really appreciate in the bill. And I love what Dr. Bill put in we are not civilized as a country because we don't provide healthcare. Yes, and so much more. Major countries, he's saying the other word that Bernie uses is major countries. I don't know.
So we're close to the end of our time. And so I want to thank everybody who joined us on Zoom. I want to thank everybody who has joined us on Facebook Live. I want to really also thank Dr. Sara Deen for her powerful hosting, co-hosting and moderating and responding to what people brought up, and her actually insistence that the individual human story is the reason to make this change, right? Like there's so many different ways that our system fails people, but you can look at cost savings and some pretty abstract stuff, but how can you put a dollar value on some of the experiences that Betty Dumas just shared with us, right? Those are costs that even in the sort of kind of the chilly healthcare economics, which entirely favors doing a bill like this, by the way, can't begin to really put a social value on those costs. So I'm so grateful for everybody's participation. I usually want to encourage everybody, by the way, there's a little bit of cost to some of our just promotions for doing this event every week. So if people out there are able to give a few bucks to Healthcare for All Los Angeles, that we appreciate that. But to end, Sara, do you want to kind of give us a closing thought?
Yeah, I just wanted to say, and of course, we all bring our own values into these spaces. The way I was raised was to always remember that there's always folks that have a little bit more, and there's always folks that have a little bit less. But when it comes to this work, to think about, because I've heard a lot of people say things like, well, I'm pretty happy with what I have. I'm able to afford the supplemental on my Medicare and I get pretty good care, or I like my insurance. Well, that's great. But what about everyone else who can't? Which is probably the vast majority of Californians. In most value systems, in most faith traditions, in most communities around the world throughout time, we're all called to think about the person and to take extra care and extend extra compassion for that person, the person that has a little bit less than you, to center the voices and the needs of the most vulnerable in your community or in your society. We've become a zero-sum game the way we talk about any issues, right? You're either pro or you're anti, and you kind of had to pick a side. And so many people get lost in the gaps there. There's a great, I would suggest everyone look at this. There's this great article called, it's about the ring theory. I don't know, Ron, have you guys heard of the ring theory? So the ring theory was two therapists wrote this article about how to extend care to someone who's going through hardship. The example they use is cancer, right? So suppose your neighbor has cancer. The center of that ring is the person who has the cancer. The next ring is the family, and so on. And you might go out to, the general community, but you center the person that's most vulnerable. I've seen it then, Muslim ARC applied this to racism. How can we be allies in the movement for anti-racism work? And the author applied, Namira, she applies the same principle, that when you're having conversations around race, look in the room and who's at the center, right? And where do you fit in? And you provide care and support in, and you dump out, right? So as a brown person, I can offer care inward to a Black person who's more impacted. And if I need to dump or share my experience of racism, I can share that with someone who's less impacted, like Ron, right? Same thing when this model of the ring can be applied in any issue, I would posit. So for example, when we're thinking about how to solve our healthcare crisis, I am urging whoever you are, whatever your own particular circumstance is, whatever insurance you have, whether you have awesome insurance, you have no insurance, I want you to think about that person that's the center of the ring, the most vulnerable human being. So if you're an assembly member and you're casting your vote, or you're a resident and you are thinking about talking to your assembly member, or you're in your community talking about healthcare reform or single payer healthcare, I want you to carry that person in your heart. Put your own self aside and find that person who's at the center, most impacted of our current healthcare system. Think about that person, center them in your problem solving. So that's just something I wanted to share. And I also want to encourage everyone to visit the website for Healthcare for All. It's healthcareforall-la.org. And if you click on Take Action /CalCare, you can make a donation. I'm new to this group, so I feel like I'd like to pitch this. I was surprised to find out that these folks are volunteers. I had no idea. I thought they were all getting paid. This is all volunteer work. A lot of people are putting in a lot of their expertise and their skills into this work. So any support would really help this really awesome group of people carry this work on. So please visit the website and click on Take Action /CalCare. And, oh no, I'm sorry. If you go to the website, there's a button now that says donate, and you can donate to HCA-LA. I would really urge you to do that. It's a good group of people, and they're working every day for you, for that person who's at the center of that ring.
Well,
and thank you for letting me co-host with you. It really was an honor.
My thank you, and there's nothing to add to that. Certainly, what a thoughtful end to our to office hours, and we'll be back next week from 5 to 7, because we're always going to be back until we pass this. And with that, I'm going to end our meeting.
Yeah, Ron.
Thank you.
Are we still live? Oh.
Yeah, we are.
Thanks.
No, but I'm gonna end it, because if we don't, we won't end it. So
I just wanted to thank you, and I think it's incredible that you invest this time every single week. I don't know how you do it, but thank you.
Well, because it needs to be done.